Prakash, I have to thank you again, but this time for being a sacrificial cardiologist. So my disclosures, I'm one of the founding consultants of Silk Road Medical back in 2007. So I firmly believe that TCAR has a place, and I like where it's gone. I'm also a member of the Multi-Specialty Carotid Alliance, who recently petitioned CMS and Medicare to reopen the national coverage decision for transfemoral carotid stenting. The final decision should be out, assuming the government doesn't shut down, on October 11th. And I'm a consultant to multiple industry manufacturers. So you may or may not know this, but all carotid patients comprise about 25% symptomatic and 75% asymptomatic. And the FDA has approved at least 7 systems, carotid stent systems, for use as safe and effective. In fact, no carotid stent system has ever gone before the FDA in a major trial and not passed its objective endpoint. However, CMS only covers the high-risk surgical patients, which is a very small percentage of the total population of carotid patients. And they parsed those data without any real kind of basis, but they did it anyway. So since that last national coverage decision, which was in 2008, there have been multiple papers published, randomized stenting versus surgery. The first everybody knows about, this is the CREST trial published in the Journal of Medicine in 2010, showing for the primary endpoint of stroke, death, and MI at 30 days plus ipsilateral stroke out to 4 years, no difference between stenting and surgery. And if I can kind of shortcut this and paraphrase, if we look at the primary endpoint, there were no differences. If we look at cranial nerve injury, in fact, there was a disadvantage to endarterectomy with about a 5 to 6% 1-month cranial nerve injury and about a persistent 2% at 6 months. Now, this doesn't sound like a big deal, but some cranial nerve injury can be quite disabling. And so while it's not a stroke, it certainly falls into the neurologic disorder category. Access site complications actually favored carotid stenting. There were more takebacks and hematomas at the neck in the endarterectomy arm in CREST. Long-term durability was very good in both arms for stroke prevention and for patency. Cost was equivalent in a prospective study, and so as was quality of life, more or less equivalent, although in the first 30 days it was advantage to stenting. Second trial, so the first trial was 2,500 patients. The second trial was about 1,500 patients. And it was a randomized trial in asymptomatic patients, also a good risk for surgery. It was the Act 1 trial published about 6 years later. And again, no difference for the primary endpoint between stenting and surgery. A third trial, ACST2, randomizing asymptomatic patients in 3,500 cases, 1-to-1 between stenting and endarterectomy. And again, found no difference in the primary endpoint of death or fatal or disabling stroke out to 5 years. And if you look at the subsets, there were no differences in any of the subsets. And in fact, since the last national coverage decision in 2008-9, there have been over 6,500 patients randomized in asymptomatic trials for carotid stenting versus endarterectomy, all of which show no difference between the two therapies. And in the symptomatic population, over 3,000 patients randomized, and again, no difference between stenting and surgery in these populations. Now, I want to go through the TCAR data because it's only fair to compare the data. Oh, I'm sorry. Something must be wrong. There's no data. I'm sorry. Could you check with could you guys check this slide? There may be a problem here. So, I know I was kidding. The slide works fine. There's no data. So, you know, I mean, I like TCAR. I think it does a really good job, but you can't say that it's equivalent to endarterectomy, or you can't say it's better than stenting, even if VQI says so, because it's never been randomized. And everything else is selection bias and ascertainment bias. It's the holy grail of non-randomized trials. Okay, so let's move on. TCAR, does stenting by any other name smell as sweet? Well, Peter went through the Roadster trial data set and I think represented it very, very fairly. You can see here that if we look at the per protocol analysis, the stroke, death, and MI rate at 30 days was 3.5%. Stroke and death rates, 2.8%. Very acceptable in a mixed population of high-risk surgical patients, but not randomized. If we look at carotid stenting and we look at the improvements, a lot of folks are stuck back here. They say, well, stenting's got a really high complication rate. No, no, no. Let's go here. And the complication rates are now in the 2 to 2.5% range. And they've come a long way in a very short period of time. In adverse circumstances, I would submit without reimbursement. If we look at the Roadster trial comparison, intention to treat across the broad spectrum of cases, mixed like this were, in the high-risk populations like these were, in fact, Roadster matches up about the same, but stenting actually is a little bit better. But these are contextualized or not directly comparable. So I don't think there's an advantage of TCAR, and certainly it's not been randomized against anything. So we have more recent data, which is not randomized, but very tightly adjudicated. It's the CREST-2 registry. In this case, there were about 2,000 patients, about half of them symptomatic, about half of them asymptomatic. Today, there are over 9,000 patients, and we're looking at that analysis to update and refresh this. But this was published in 2019, and we found that in the asymptomatic population, 1.4% stroke or death, and in the symptomatic population, 2.8% stroke and death. Well, how does that line up with the Roadster data sets? Symptomatic patients, it's about half, and asymptomatic patients, it's about half. So again, in a non-randomized fashion, CREST-2, non-randomized, TCAR, Roadster 2, non-randomized, we find that the rates of complication are about half of what they are in TCAR. So TCAR is a good way to place a stent if you're a surgeon. And frankly, it's been a great experience, most of which has been eaten away at the endarterectomy population since 2017 in the introduction of TCAR into the mix. So it has been a successful experiment, and I think probably to the benefit of patients, but unfortunately without randomized data. My point about all this is it's not fair to bang on carotid stenting as an unreasonable choice when it has been proven in multiple randomized trials to be very successful. Now, one of the things that TCAR trots out is that it does have good data on new asymptomatic DWI lesions after intervention. And this is a mechanistic demonstration of embolic burden during a procedure. So you can see endarterectomy here at about 17% new DWI lesions, and TCAR doing nicely at about 15 to 20%, about 15%. Okay, well, there are new devices now on the very near horizon. The results for both of these trials will be at the Viva late-breaking meeting in about a month. This is the NeuroGuard. This is the all-in-one, 3-in-1. So it has a 40-micron filter that's deployed underneath a standard filter. This 40-micron filter is remotely actuated at the handle. It provides exquisite embolic protection. There's a balloon and a stent with a sheath covering. So basically, you put this up over your filter, you deploy the 40-micron filter, you unsheath the stent, you blow up the balloon, you take it down your filter, and you pull everything out. You're done. One step, no exchanges. And if we look at the other trial, it's the CGuard Micronet carotid stent system. This trial is called the Guardians trial. It's almost done. It is done. We'll report 30-day. Both trials will report 30-day data. This is a mesh-covered stent. Both of these have shown in very nicely performed trials, their new DWI lesions have been reduced from what used to be about 70% in carotid stenting to now well in the range of TCAR and endarterectomy. Here 20%, here 35% for the stent and for the filter. So like Peter, I think that there's probably a complementary role for these therapies. I'm not going to go through this slide, so don't worry. But I think it's a Venn diagram with lots of different ways of managing patients. And again, like the other debate I just did, there's no one therapy that fits every patient. Every patient has to be tailored to the specific problems they have, their anatomy, their comorbidities, the lesion type, and so on. And I think that based on what we know, and we know a lot already about these therapies, I think we can make coherent decisions about them. So in summary, no single approach is best suited for all patients. Majority of patients requiring vascularization could probably be managed safely with any of these therapies. Select patients may be better treated with one versus another. To that end, most operators will not be proficient in all modalities. Peter's an exception. So find an operator that doesn't mind referring for the sake of patient's best outcome. I refer a lot of patients now for endarterectomy based on what I know about stenting. And when all medical and device surgical options are available to all patients, outcomes for the management of atherosclerotic disease will finally be optimized, and we'll have the lowest rates of stroke, lowest rates of death and disability. And that's really should be the goal. So I would change the title of this talk to Transfemoral Stenting as my complementary choice of treatment. Thank you very much.